Hi, everyone. Thank you for joining us for the 22nd in our series of webinars on preventing and managing COVID-19 in the workplace. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare. We appreciate your weekly participation, and for any of you who are joining us for the first time, welcome aboard. For the duration of the session, you will be on mute. Please submit your questions using the Q&A function in Zoom. We'll answer as many questions as we can at the conclusion of the presentation, which typically lasts about half an hour. We have 10 minutes reserved for questions, and we try to wrap up within 40 minutes. Any questions that we don't have time to answer, Dr. Harris will answer later in writing, and we post every week the answers to all questions on our website, and you can find those on the resources page. We also post a recording of each session on our YouTube channel. During the session, Alexis, who today is actually Mia Prine, who's substituting for Alexis, who has the day off, will be posting that for us. Let me introduce our speaker, Anthony Harris, MD, MBA, MPH. He's our Chief Innovation Officer and Associate Medical Director for On-Site Clinical Operations. He's also our lead clinician for our COVID-19 response, and he has presented all 22 of these sessions, so we owe him a big debt of thanks for sharing his knowledge with us. So I'll turn it over to him. Thank you.
Excellent. Thanks everyone for joining once again. Without further ado, if you're rejoining us, you know the format, and so we'll jump right into it. If you're new to us, the format is straightforward: clinical update, followed by going over the microbiology and the pathology of SARS-CoV-2, what's novel. And then epidemiology is a review of all of our statistics, both from the micro US level to the macro global level. And then we'll talk about the preventative issues we want to address this week, and that is particularly how do we have sustainable, how do we encapsulate sustainability around our testing and surveillance when it comes specifically to COVID-19 testing. And then we'll address how we are looking forward to executing this with regard to the workplace strategies with WorkCare. So when we talk about the clinical update for this week, we want to add to the list something that's more rare, but nonetheless important, and just to look out for in particularly our older populations, and that's confusion and delirium. And there has been examples of and case studies, as well as some series studies on delirium amongst those who present neurologically with symptoms from COVID-19. And we know that the older individuals, 65, 70 or older, are more likely to present in this manner. And we want to inform you so that, again, not only if you have the aging workforce that may be vulnerable and present with some confusion, delirium, we also want you to educate your worker population so that we're taking care of the most vulnerable in our population in general, grandma, grandpa, etc. And so when we talk about what was reported in Journal of American Medical Association back in April, data from Wuhan, China was observed, and 214 patients with coronavirus was examined. And of this, the population that presented neurologically with confusion and neurologic manifestations was 78 patients, which was about 36.4%. Okay, and so again, it's not a new presentation per se. It's been around. We know that neurologically COVID-19 is affecting individuals, but we want to be cognizant to some of these things that we haven't spoken on specifically in the past, so that everyone is aware of some of the more rare presentations that we all should be aware of and have some level of education around. All right, so let's talk about now the pathology update here. And we're going to approach this from a little bit different perspective. We're not going to talk about cellular processes or viral processes in this pathology update, but we are going to talk about what's germane to the microbiology community, the pathology community, and that is the perspective and the understanding that laboratories across the U.S. And are still experiencing not necessarily discrepancies, but difficulties with regard to accuracy of testing. And we've talked about this numerous times before in regards to trying to understand the accuracy of tests that are being performed locally at whether it's the CVS down the street or whether it's the local hospital. We want to really dig in and understand how these laboratories come about in regards to testing for COVID-19. And to that extent, the guidance that's out there for these laboratories is pretty extensive, right? The College of American Pathologists, in this case, has published guidance for laboratories to establish how to establish testing for their facility specific to COVID-19 to help address the resource constraints that we all are experiencing, right? And in this, there's guidance specific to the accuracy and validating the accuracy of any kit from a manufacturer that these laboratories would endeavor to employ in their facility. Okay, and this is not to be alarmist, but this is, I want to point out this next point so that we're all aware of the tremendous difficulty that still exists around accuracy of the testing and why we're still lagging behind in regards to performance of preventative strategies in the US. And this guidance specifically, and we're going to read this all the way through because it kind of blew my mind a little bit. While the ultimate objective is to fully verify the method performance of the assay, pandemic crisis, the urgent need for patient testing, and the possible lack of reagents and supplies make it difficult to fully evaluate the accuracy, precision, and reportable range, as stated in one of the guidance documents, COM 4300. A more limited approach may be acceptable. You and your laboratory director should determine the depth of verification needed to begin testing. Your laboratory director must approve that methodology, right? And so this guidance document from the College of American Pathologists essentially puts it in the hands of the laboratory owner clinically, right? When I say that, there's a pathologist in general that is over that laboratory and responsible clinically for all the performance of the tests. And the traditional way that is a little bit more lengthy of verifying the validity and the accuracy of the tests, in this case COVID-19, sometimes gets skirted, right, or gets truncated. And so that only adds to the difficulty we have on this end of the clinical evaluation at understanding the accuracy of the data that we get back in regards to positive or negative tests, okay? And this is going to be, keep this in the back of your mind, because again, this is going to be even more important as we begin to talk about pool testing. You saw that terminology used in the introduction of this session for today. And pool testing, in short, is a methodology by which we can become more efficient, perhaps, and more cost-effective at doing long-term diagnostic as well as surveillance testing for our worker population. And pool testing guidance is also given by the College of American Pathologists to laboratories so that laboratories are aware of when to and how to deploy pool testing when appropriate, okay? And so we won't go through this document in detail, but just know that pool testing is a viable way to move forward with surveillance as well as diagnostic tests with regard to the workplace with COVID-19. So let's jump into the numbers. The epidemiology trends that we're tracking obviously is the trend from week to week of our number of cases here in the US. We were at 4.28 million cases 2 weeks ago. Last week went up to 4.69, almost 4.7 million cases. And this week, well over 5 million cases, right? Number of deaths have continued to increase as well, 162,000 deaths. This is a graphic here I want to show you. Oftentimes pictures speak louder than words, right? I'm going to stop the presentation, pull this over here so that you can see it. It doesn't play properly in the mode here, but what you're seeing is a tracking of illness. What will play out here is a tracking of illness across the U.S. in terms of total number of cases per 100,000. Okay, and as you're seeing the color change, shifting towards the red color, you're seeing a density increase of incidence of COVID-19. And I wanted to represent this in a powerful way, and oftentimes these time-lapse films do that really well. You can find that video if you want to replay it for your folk on YouTube. The link is down here. That came from Dartmouth College, all right? So getting back into the presentation here, we want to look at then the number of deaths based on the CDC data that we've been tracking from week to week. And we can see here to play out 2 weeks ago where we were with number of deaths above 5,000 in the dark blue, increasing in several states last week and continues to increase this week as well. The trend of the number of cases that the CDC reports on a daily basis 2 weeks ago was trending up, began to flatten out and maybe curve down a bit when we looked at the statistics from last week. And we see a decreasing trend here now, clearly with the number of cases. Obviously still a high burden of cases in total sum, but when we look at the actual rate or incidence, we're seeing the curve both flatten and decrease here. So how are we doing macroscopically at the global level? With regard to the US, this was where we were 2 weeks ago. The US obviously still leading the way in terms of total number of cases, documented total number of cases in regards to prevalence of illness. This was back on the 29th of July. On the 5th of August, we started to flatten the curve, and we're seeing still a decrease in that curve here as we look at where we are today. We also want to examine, in addition to this 7-day rolling average of daily new cases, the update on deaths, okay? 7-day rolling average with regard to deaths. We saw the death rate increasing on a daily basis, tracking along with the increasing incidence. And we continue to see that perhaps with a little flattening of the curve. And now that curve clearly is flattened and hopefully will be decreasing over time as we continue to watch this metric week to week. We looked at how we're doing with regard to the U.S. compared to other nations from the perspective of what percentage of the tests that we're conducting are coming back positive. This is a 7-day rolling average. We've looked at now for 3 weeks in a row. Obviously, you see Mexico here off the charts in regards to number of positive cases. That means they have a tremendous amount of distance to make up in regards to the number of tests being conducted. If we look down at the U.S. Is down just below India in terms of our numbers. What we want to specifically look at, though, is are we decreasing in percentage, which would represent then that we're more accurately articulating the burden of disease in the U.S. in this 7-day rolling average. Here's where we are this week compared to last week, roughly in the same area, perhaps a little decrease in regards to the rate or the slope of that. If we isolate the United States, we can see that trend here a little bit more clearly as we're decreasing slightly in that percentage of positive tests conducted overall. So now, when we talk about looking at the approach here to our preventative strategies, we talked about last week the screening, the remaining at home, the whole process here in terms of COVID testing, local testing, and the return to work process. And we spoke about this in a way that allowed us to fully understand, do we have the best baked plan with regard to prevention in the workplace? We want to zero in again this week now, not just on the process and the cycle of local testing, but we want to zero in on on-site testing. Obviously, on-site testing being local, but being specific to at the workplace and not sending someone down the street to the CVS or to a local hospital. How can we make this process sustainable? And how can we focus on key areas here, okay? Continuous surveillance of the workforce. We want to focus in on sustainability, right? Making it cost effective. And then we want to focus on opportunities for worker participation, all right? And we'll touch upon the sustainability continuous surveillance, and we'll perhaps next time get more into the worker participation and how we can boost participation from these surveillance programs here. So if we look at and examine information and data on pool sampling, okay, we want to get into the details here of what exactly is pool sampling, what exactly is the overall approach, and can we use it? Can we use it sustainably? Our friends across the pond are ahead of us on this, frankly. Germany has been leading the European Union in terms of doing pool testing and doing it and studying it successfully with regard to COVID-19 specifically. If we look at other examples of performance of the pool approach with regard to COVID-19 specifically, we have an approach that can be bifurcated into two methodologies. And we'll get a little bit more into that here shortly. But I want to introduce in a little bit more detail the concept of pool sampling. And this concept is, in short, taking a population, in this case, let's say 100 workers, right? And we're going to take those 100 workers and break them out into smaller chunks, smaller groups. In this case, and what some studies have looked at is, what if I take that 100 and break them down into groups of 20, okay? Then I can test those 20 individuals collectively by pooling their sample. Let's say we're doing a swab test, right? We swab all 20 of them, and then we place those swabs and collect them into one conical. And that one conical or test tube then is placed in this case, whatever testing methodology at the laboratory that is deployed. This is a well, and commonly used those little wells there are placed into the PCR machine. And this molecular test then is going to report a positive or negative result for that group of 20 individuals, okay? And likewise, you continue to test the other groups of 20, and when you successfully have tested all 100 people, perhaps only one group comes back positive. And you can then move forward with testing that group in individual fashion, so that instead of testing all 100 individuals and the cost and the time associated with that, you're testing individuals only in that positive cohort. And that's a way to improve, obviously, the economics of pool testing. It does obviously extend the timeline for pool testing, and we can see that more clearly if we look at this another way. We call this methodology the adaptive pool testing method, okay? And there's kind of two tiers, and there can be more than two tiers, but in this case, we'll start with just kind of a two-tiered approach, where you have the master pool depicted here in that gray shaded circle there. That represents the 100 individuals of a particular pool, and we're going to break them out and test them individually in this case, in groups of 10, right? And those individuals then are identified, and that scheme is a one-tier scheme. You're not learning and continuing to test beyond that first tier. Compared to the two-tier or three-tier system, it's actually called, the master pool in this case represents still that 100 individuals. They're broken out into groups of 20, so 5 groups of 20. Those groups that are positive then get individually tested, and you find those individuals that have positive results, right? And this approach, again, is going to lengthen the amount of time it takes to get to an individual reported case, but it's going to decrease the amount of resources that are required to reach that inevitability. So the approach, again, adaptive pool testing, uses kind of a manual approach, if you would, in regards to collecting samples, testing samples, and then subsequently testing those positive individuals in that pool. There's the other approach. This is a non-adaptive pool testing method. Gets a little bit more complex in terms of how to structure it, right? It uses a statistical analysis to understand who may be positive in a particular sample as well as at the individual level, okay? And we're not gonna get into the nitty gritty of the statistics, but we wanna try to oversimplify, if we would, if we can here, the process. So imagine that we have a pool of individuals, in this case, let's say 300 individuals, or we'll stick with our 100 individuals, right? And in that sample, we know that a number of individuals will be positive if the prevalence or incidence is, let's say, 1%, right? Or maybe even 4%. So those individuals are placed into those same kind of pools of conicals. But the difference here is that you're going to take an individual sample and you're going to place it into 4 different conicals. And that's what's represented here on the right side. So the blue dot there is one individual. The red dots there, let's say sample 1, 3, 7, and 9, are all conicals or test tubes that have multiple individuals sampled in it. And so one person will be represented in a sample multiple times, in this case, 4 different times. And then you test all of those different test tubes, those different conicals. And as you test them and they come back positive, you can use statistical analysis to understand what one person made each of those conicals positive, and you can exclude others because they were in pools or conicals that were negative, right? And so I know that oversimplifies it dramatically to the stoichiometric, or to the statistical analysis, but the approach has been used in Germany, has been used in European studies, and it has been used in a limited fashion here in the US. But it is an approach that gets you more quickly the answer of who or which individual is positive. And I'll restate that here. So as opposed to the more manual approach, right, you have to test the initial pool, find out what group is positive, then continue to test those individuals. That takes time. Let's say it takes you a half an hour to test, to run one test, and you need to use an hour's time to individually understand who's positive. As opposed to this method where you test everyone in multiple pools, it takes you perhaps the same half an hour to run that and then do the statistical analysis. And that improves the performance from a time perspective down to that half an hour chunk, if you would. Okay, and so this method does break down on when we talk about the level of prevalence of a particular disease, in this case COVID, and if the prevalence is higher than 4 people per group, if you would, then the statistics don't work out, and it becomes difficult or even impossible to narrow down to one person who's causing each of the samples or the aliquots to be positive. So there are limitations of this approach. But when we look at what is being contemplated by the FDA in the US with regard to pool testing, it's more the manual approach than it is the statistical approach. So now let's talk about definitions, okay? I want to make sure we're crystal clear on the different definitions. We've touched on these before, but I want to reiterate them on testing, okay? There's diagnostic testing. We won't read the whole piece here, but in short, diagnostic testing is testing when you have a reason to test. If you're, if my sister comes back positive for COVID, it's because we sent her for testing because she had symptoms or because she had an exposure or some other trigger to cause her to be tested, okay? That's a diagnostic, considered a diagnostic test. That's compared to a screening test where there is no reason to particularly test an individual or a group of individuals. There's no exposure, there's no known symptomatology that could be asymptomatic, but in that scenario, right, you're screening individuals and you wanna see if there are individuals who are asymptomatic in the population that are positive for COVID-19. And that's kind of the sustainable approach we wanna focus in on. And then there's surveillance testing. Surveillance testing is more akin to what the local health department is doing in regards to testing an entire population to fully understand the burden of illness in that community so that resources can be appropriately proportioned to that group of individuals or to that community. Okay, so we want to make sure we're crystal clear on these definitions because that is going to predicate our approach as we talk about now what we can and can't do with our approach from not just the work care standpoint, but from all clinicians and all the occupational health constraints that we have in the US at this point in time. So we want to answer the question, can we do pool testing and can we do it tomorrow, right? Simplistically. And is it going to be sustainable for us immediately or in the future? And so the answer to that is the CDC does give some good guidance, primarily to laboratories, right? So this guidance on pool testing is quite expansive. I was surprised weeks ago when I first discovered and they first posted this, right, back on, and they updated it back on August 1st. But it is not meant for our typical EHS professionals. It's meant for the laboratory to understand pool testing, what are their options, and how do they approach pool testing in their local community. Nonetheless, we can glean from this and learn from this several things, okay? And one of the things we want to glean from this is particularly, again, keeping those definitions in mind, what is going to be our approach and our options as we move forward and to manage our workforce with regard to pool testing specifically, okay? And we'll break it down. We won't go through all the text here. We're going to break it down into these simple charts that the CDC has published. And it's all governed around, for the most part, what needs and requires FDA approval to do pool testing and what doesn't. Okay. And when we say FDA, there's another piece to that called CLIA. We spoke to that perhaps briefly in the past. CLIA is just the protocol or the legal ramifications for conducting laboratory tests on people in the US. It came about back in the 60s to help increase conformity amongst physicians and practitioners who were doing testing in their own clinical setting, right? And so a CLIA certified laboratory is required if you're going to do any level of testing, whether it's surveillance, screening, or diagnostic testing for pool sampling. Okay. When we talk about surveillance testing, you can actually perform surveillance testing also if you're a non-CLIA certified laboratory. And there's options there if you're in that scenario, but know this, none of our employers are in that scenario, right? We don't want surveillance testing only, and we'll talk about why in a second here. And then CLIA requirements apply to pool testing. Yes, that's true for screening and diagnostic, not for surveillance. We'll explain that in a second. And then lastly, does the FDA need to authorize whatever test or methodology for pool sampling if you're doing surveillance? The answer is no. But if you're doing screening and diagnostic testing, the answer is yes. Now recall, screening and diagnostic testing is testing individuals because either in the diagnostic testing, there's a reason to, or if we're trying to manage and prevent workplace exposures, the screening test becomes relevant, okay? So we're gonna focus in on that. So when we talk about then returning the actual approach to the pool testing and returning results to the individual, this is the guidance that becomes important to us and why we can't leverage at this point in time pool testing for surveillance purposes that is exempt from FDA emergency authorization approval. And so if you can see the chart here, it clearly says if you're doing surveillance tests, you can't report to individuals. It's only at the macroscopic or community health level that you can report results in regards to the pool being positive or negative, okay? And that again is to get an accurate picture from an epidemiology high level standpoint. But when it comes to diagnostic and when it comes to screen testing, you can report after you conduct pool sampling, but only if you conduct, only if and after you conduct individual testing. So again, you have to test at the individual level in order to report any negative, positive, or indeterminate results. And so that's important, right? That's important to know. That's important to keep in mind in regards to our planning as we move forward. And so at the end of the day, if we distill it all down to what can we practically do, not just here at work here and offer to our clients, but anywhere at this point in the US, it all comes down to, are there approved, FDA approved, and emergency use authorized tests, laboratories for pool sampling, Okay, and there's hope because the answer to that is yes, but there's only one. And that first approval came July 18th, and it was Quest Diagnostics that received that approval. So at this point in time, if the answer is yes, can you do pool sampling for diagnostic and for surveillance purposes, or excuse me, for screening purposes, not surveillance, diagnostic and screening purposes? The answer is yes, but there is a tremendous resource constraint because it's only through FDA. Now, will this change? Obviously, yes. We've seen the number of tests approved for just diagnostic in and of itself, testing over time. We're going to start tracking this now, and through this opportunity and webinar to see how many tests are going to get approved and track the increased access to pool testing, so that we can now leverage this as a sustainable solution for our workforce in a cost-effective way. Okay, so I know we went through a lot once again today, but we got to understand what our options are when it comes to sustainability around our COVID-19 testing, and this is going to be one of the key ways we can do that, as they have been doing across the pond in Europe and other nations. So with that, I'll stop here and we'll take some questions. Thank you.
Okay, thanks, Dr. Harris. I think we're going to get you an early Christmas present and improve your microphone, because we're still having some fading issues. So we'll work on that and get you clear as a bell next week for those of you who are having some audio issues.
Got it.
First question, how much confidence should we have right now in testing overall based on the information you presented initially, and then following up with the limitations on the availability of pooled testing?
Sure.
Say you're an employer and your employees come to you and say they're not all that convinced that testing is all that valid. What should the response be?
Sure. So, I mean, if you look at what CDC has recommended in terms of testing as a means for return to work, or return to play, however you want to put it, they no longer recommend a testing method, right? They recommend a clinical clearance versus testing clearance. Does that mean we stop testing? Absolutely not, right? But it does mean that the reliability of testing, the access to testing is such that it just doesn't make sense in every scenario. And leaning on your clinical resources, your clinicians, your doctors, your nurse practitioners to individually clear and use criteria, obviously, given from CDC, WHO to do so is the way to go for now. So we addressed this last week in terms of, and there's still some confusion out there with our clients that the perception is, if I get a negative test and I'm quarantining because of an exposure, can I get back to work just based on that negative test sooner than the prescripted and recommended quarantine or self-isolation period? And the answer to that is no. And why? Because of the limitations that pertain to the accuracy and reliability of the test as it stands today. Okay,
thank you. Here's a question about the adaptive pool testing method. Should worker proximity to each other be taken into account when creating subpools of the master pool?
Yes, in a way you can look at creating the subpools based upon already natural groups, if you would, in the workplace in regards to how people are working next to each other, adjacent to each other. There is, when we're talking about creating subgroups, there's no defined way to create those subgroups that particularly increase the accuracy of the results or speed of the results. So that factor is not relevant for the actual result efficacy, if you would. However, it just may ease the logistics of creating those subgroups if you are already taking into account those workplace proximities.
Okay. This is switching over to a question about masks. Some of you may have seen this new Duke study that just came out regarding the effects of different face coverings. The question is, it was noted in this study that the neck gaiter or buff style face covering actually produces more aerosolized particles and is worse than wearing anything. What are your thoughts on this study's findings?
Say that last piece again. You said it was actually worse. I cut out just a bit.
It says in the study that the neck gaiter or buff style of face covering produces more aerosolized particles and is worse than wearing nothing.
Yeah, yes. So the buff style or the neck style cloth covering, the variability is just substantial, right? In terms of the layers of cloth. Oftentimes in the marketplace, what we're seeing is that those layers are single layers and maybe at the most kind of a dual layer of thin material. So whether or not, the manufacturer took into account actually reducing the particles is yet to be seen, because there's so much variability out there, which is why those masks are being shown to be less effective, because they're so thin, right? And if we look at kind of the guidance that the Secretary or the CDC has put out, as well as the Secretary General, it's to take a cloth covering and specifically fold it several times, creating multiple layers, so that you have that decreased transmission that we are looking for.
Okay, so this reminds me of a question that came from one of our clients, where employees have said, what's the point of wearing a mask? It's like using a chain link fence to stop a gnat from coming through. So I wondered if you could just really quickly explain about the size of the viral particles as opposed to the size of a droplet, and what a mask is preventing from going through, and why multiple layers make sense.
Sure. So, I mean, the masks themselves are, the cloth masks themselves are not designed to stop the viral particles, right? The virons themselves are about 30,000 Daltons in size, considerably larger than flu particles, virons, but again, small enough that they can pass through regular cloth. So the goal is not to stop those in and of itself viron particles. The goal is to stop the droplets that those particles live in. And it's the droplets, those droplets that we form typically are between 5 and 20 microns, okay? And it's the particles that are 5 microns or smaller that get aerosolized and float around in a virtual Oort cloud around our cells, okay? And those particles are the ones we want to prevent, because those are the ones we want to prevent inhaling. Right, and the particles that are larger, the 20 microns or larger, those are the larger particles that fall to the ground because of gravity relatively quickly. Right? And so the cloths are designed either by design of manufacturer or by design of, hey, I made it at home, to prevent those droplets that carry the viron from being aerosolized. And studies have been shown that if done correctly, it's effective. Right, and as opposed to the N95 masks and other filter masks that are designed to actually filter out viron-sized particles. And so that is the approach that needs to continue to be promoted to help keep us all safe.
Okay, we have time for one last minute quick question, and it's a demographic question. Do you know what the average age of death is due to COVID? It doesn't specify what country or globally. The question is, what's the average age of death?
If we look at kind of the inflection rate or the inflection point with regard to age for increased mortality,